Hi friends, welcome to Plexus Ortho. My name is Dr. Kannan Kumar, and today we're going to discuss MCQ number 200 that we put up a few days ago in the Telegram channel. So the MCQ is as follows: which of the following parts of the scaphoid has the highest propensity to undergo avascular necrosis? So they're giving you the parts of, they're saying there's a scaphoid fracture, and they are giving you the parts of the scaphoid, including scaphoid tuberosity, waist, proximal pole, and distal pole. They're asking you which one has the highest propensity to undergo avascular necrosis. The right answer for this is proximal pole. So I hope a lot of you got this question correct. And it's a very simple, straightforward question. Scaphoid is asked very often in the exam, and all of you must be able to answer this question confidently. So, what are the parts of a scaphoid? The scaphoid is shaped like a bean or a twisted peanut. It's shaped like a twisted peanut, and it has the following parts. It has what is called as a scaphoid tuberosity here. It has the waist portion, that the fracture can happen through the waist. It can happen through the proximal pole. This is the proximal pole. This is the distal pole. So the fracture can happen through the waist and through the proximal pole portion as well. So the vascularity of the scaphoid is weird. See the vascularity. There are two blood sources that come into the scaphoid. One is through the dorsal side, which is the major blood supply, and which comes from the dorsal distal towards the proximal side, and therefore any disruption to the blood supply here will cut off the blood supply here as well. So we know that the scaphoid has a dual blood supply. So this is the dorsal distal portion, and which gives blood supply up to the proximal pole, and then we have a superficial arch branch which comes volarly, which gives to blood supply to the distal pole. So therefore the proximal pole is very vulnerable. It has a single blood supply, and it can get cut off with any fracture at the level of the waist or the proximal pole. So therefore proximal pole fractures have the highest propensity to undergo avascular necrosis. You can see this picture. This is the distal portion, and this is the proximal portion. As you can see, the rate of new union of the scaphoid decreases as we go more and more proximal. So if the fracture line goes more and more proximal, there is a higher chance of AVN and more chance of non-union. This you must remember. So if they give you a MCQ question, ask you where does the AVN chance is very high, whichever fracture is more proximal, that fracture will have the higher chance for AVN. This you must remember very clearly. 75% of all of the scaphoid is covered with articular cartilage, and therefore because it's bathed in synovial fluid all around, there is a higher chance of non-union because there is no extra osseous blood supply is very poor to the scaphoid. It all has to come intraosseous, and therefore any disruption to the intraosseous blood supply can cause avascular necrosis. This must be understood very clearly. So how do you manage these scaphoid fractures? If they are undisplaced or minimally displaced fractures, the best form of management, what is this called as? Glass holding cast. Glass holding or scaphoid cast is put. It is the thumb is also included in it, and it is a short arm cast or a below elbow cast, leaving the fingers free up to the level of the proximal third of the forearm. This cast has to be kept in place for up to 6 to 8 weeks. Right? So how do you diagnose scaphoid fractures? Scaphoid fractures are diagnosed by tenderness in the anatomical snuff box. What are the boundaries of the anatomical snuff box? The boundaries of the anatomical snuff box are: medially it is the EPL tendon, laterally it is the two APL and EPB tendons of the first compartment, and in between these two is the anatomical snuff box. What are the contents of the anatomical snuff box? Beneath are the radial artery. You can palpate the radial artery when it goes volar to dorsal side. The second thing is a few of the superficial radial nerve branches can be felt there and goes there. The third one is the cephalic vein continuation is also present in this anatomical snuff box. Also deep portion contains the scaphoid bone, and therefore when you palpate it and when there is tenderness, it indicates a scaphoid fracture. Also you can press on the scaphoid tuberosity, which is on the volar aspect, which also indicates a scaphoid fracture. So if at first you suspect a scaphoid fracture and you cannot find one on the X-ray, you cast the patient anyways, because you want to be on the safer side. If you don't cast these scaphoid fractures, they have a high tendency to go to non-unions. So you cast the fracture or cast the patient and then ask them to come back after 14 days and repeat the X-ray, and sometimes the fracture may be seen on the 14th or the 21st day, right? So what do you do in a displaced scaphoid fracture? You use what is called as a headless compression screw or a Herbert screw. You use a headless compression screw or a Herbert screw, HCS or a headless compression screw. So this does not have a head, and the whole of the screw gets buried in the scaphoid. The whole of the screw gets buried in the scaphoid. And what is special about this screw as compared to the other screws? There is a differential pitch. That means the diameter is different in the proximal end. This is the proximal end if you are passing it from distal to proximal, and this is a distal end, and this difference in the diameter helps in compressing the fracture. So when you pass the screw through the fracture fragments, when you're tightening the screw, it helps in compression of the fracture. So the treatment of choice of displaced scaphoid fracture, displacement more than 1 millimeter, is Herbert screw or a headless compression screw. So I think you have got a few points from this video regarding scaphoid fractures. The more proximal the scaphoid fracture, the higher the chance of the AVN. The most common scaphoid fracture is the waist fracture. The most common fracture which goes into AVN and non-union is the proximal pole fracture. Tenderness in the anatomical snuff box indicates scaphoid fracture. What is the method of putting a cast? It is called a glass holding cast or a below elbow glass holding cast for the scaphoid fracture. What kind of screw would you use? It is a Herbert screw or a headless compression screw to fix these fractures. So what is the speciality of the headless compression screw? The diameter is different in the distal and the proximal portion, by which when you tighten the screw, it gives compression to the fracture side. The second speciality of these screws is that, as the name suggests, they don't have a head, and therefore they are completely inside the bone or intraosseous. Why does it need to be completely intraosseous? Because 75% of the scaphoid circumference or surface area is articular surface, and therefore you don't want any head of the screw poking outside. Okay, the blood supply of the scaphoid is basically from dorsal distal to volar proximal, and therefore that is the reason why the proximal pole goes into higher chance of non-union. I hope this clears a few of your doubts regarding scaphoid fracture. With that, we end this video on MCQ number 200. My name is Dr. Kannan Kumar, and this is Plexus Ortho. Thank you for hearing me out. Thank you very much.